Yeah, so this is a challenging one.
Yes.
So dense inflammation throughout here. Oh, okay. And yeah, we'll just have to see what's in these areas.
Yeah. One thing, when you see like big fragments of tissue that are really ragged on the edges, lobulated fat and dense fibrous tissue, and it's kind of jagged edges and there's no epidermis, that always is a clue for me that this might be soft tissue from the hand or foot or right about there, because I think it's partially due to the anatomic site, but also partially due to the way that hand and foot surgeons gently dissect and blunt dissect because of all the vital, important structures in the hands and feet, that they're kind of pulling out the tissue and it tends to kind of rip away and leave these jagged edges. And I think that I don't know why, but hand and foot fibroadipose tissue has a look that's kind of different than other sites, and I think it's because of all of the tendon sheath and also because of the way the surgery is done, that it often gives it this jagged, ragged look. So that's kind of a clue. If you see a chunk of tissue like this on a test, start thinking, wonder if it's in the hands or the foot. This is from the hand, actually, per my my answer sheet. So yeah, then we'll go closer and see what's all the stuff in here. So here's one representative example. So what are we dealing with here? What kind of process do we have? Oh, I think maybe you're muted.
Sorry about that. Yeah, I got it. Thanks. Sorry about that.
No problem.
And so yeah, we have a palisade arrangement of histiocytes around neutrophils.
Yeah.
So palisaded neutrophilic granulomatous dermatitis.
Yeah, so exactly. We've got a granuloma with neutrophils. So some people will call this like suppurative granuloma, or suppurative granulomatous change, or sometimes if they get more spiky, people will use the term like stellate granuloma. This pattern right here is infection, 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 infection until you prove it's not. And even then, still might be infection. So all joking aside, this pattern is, to me, infection until proven otherwise. Aggregates of neutrophils in the middle of a granuloma, plus minus necrosis, that's usually an infectious process. And remember, the hands and feet are places where we get penetrating injury. You stab your hand in the garden and so you can get some deep fungus or some AFB or something that gets down in there. And also, it's an area where we don't want to miss infection, because if the infection gets down into a joint space, you might be talking about septic arthritis, osteomyelitis, partial amputations, serious complications. So we always want to make sure we are very vigilant to look for infection in these sites. So this looks so good for infection, and some poor pathologist did infectious stains, and they were all negative, despite how much this looks like it should be loaded with organisms, negative. But then cultures were done, and it grew out Mycobacterium chelonae. So this pattern is not totally specific for that species, but this pattern right here, I would say deep fungus and Mycobacteria infection are the most common types of infectious process you're going to see. But if you find this pattern of granuloma, that's infection until you prove it's not. So you try the stains. If the stains are negative, you can also send it out for molecular testing for PCR, which can help identify organisms. Although in cases where organisms are really rare, like the cases with stains that are negative, a lot of times the molecular will come back negative, and it's always a possibility of a false negative, because when you have very few organisms, there's very little nucleic acid from the organisms to amplify. So if it's positive, very helpful. If negative, still doesn't fully exclude infection. So usually what I do in a case like this, if I am highly suspicious for infection, but I don't see any organisms, I sign it out as, suppurative granulomas. Even though I didn't see organisms, it's highly suspicious for infection. And then I say I'm going to send the tissue for PCR testing. And in the meantime, I recommend that they repeat biopsy and get culture started, because some of these organisms can take a while to grow. So usually I want to use all the different approaches. Maybe you could argue that's overkill, but I would rather do that so we get the diagnosis as soon as possible. Even if it is a little bit more expensive to do it that way, I feel like in the long run, it's not that much more expense to make sure that we're getting an infection caught as early as possible so they can start treatment. Okay? So this ended up being Mycobacterium chelonae.